Cloud. All right, so now that we're recording again, this is April CQI. We're going to go through 3 cases and really kind of dive into the documentation in those cases and kind of what exists in the protocol, because some of them were a little bit off script, not in terms of management that happened, but just that there's no like explicit protocol for every single diagnosis. So this is the first case. This was a 60-year-old female that had been sick for a few days. Medics arrived on scene, found the patient sitting on her bedroom floor. She was confused. Her skin was jaundiced. She had coffee ground emesis in the corner of her mouth and on the floor where she was sitting. Her abdomen was very distended and she appeared very lethargic. The patient was combative with the medic crew and stated that she felt fine and didn't want to go, but was slurring her words and couldn't answer any of our questions correctly. She was still combative and refused to talk to the medic crew, but the officer told the patient she didn't have a choice anymore and she would be taken to Westchester. She continued to fight with the crews, so was given 5 of Versed IM and was shortly after moved to the Reeves. The patient was secured and moved to the medic unit. Her mom, who was on scene, stated that she had many GI issues in the past, and this was not normal for her at all. So the mental status kind of aspect of things. Placed on a 12 lead in Capno, got a 20 gauge IV in the right AC, got 2 liters of oxygen, and the patient was a bit more alert and a lot more calm with the crews. Transported to Westchester, breathing intact throughout transport, did not appear to have any active bleeding, and she had no complaints. Care was transferred to Westchester. So her initial vital signs are sort of interesting. So a blood pressure of 114/72, a heart rate of 57, a respiratory rate of 18, statting 98% room air, with 41 on the Capno, and a blood glucose of 149 and a GCS of 14. I say this is interesting because given the history, I would have anticipated her heart rate to be a little bit faster, sort of like a not particularly healthy, it doesn't sound like, 60-year-old woman with a heart rate of 57. I kind of wonder what direction that's going, what's really going on here. And maybe reasonable to get a full EKG, but these aren't grossly abnormal vital signs. So looking at kind of the documentation here step by step, the first thing is that the documentation of this physical exam is excellent. So I know that she's altered. I know that she's jaundiced. I know that she's got an abdominal exam. And so all of these things were included in the narrative and kind of up in the section where you guys do your little clicky boxes. So first of all, very good kind of inclusion of a lot of important features of this patient's physical exam, and really sets the stage for me reading this of already having an idea of like what I think might be going on. The next was kind of really documenting what this patient's mental status was. So slurring her words, not answering questions correctly, being combative, like clearly this patient is altered. And despite her statements of not wanting to go with you, this patient does not have capacity, right? So part of our assessment for refusals has to be whether or not the patient has capacity. And that means the patient is oriented, can tell you what their problem is, what the consequences are of not going with you, and really have an informed conversation. And the documentation here clearly outlines that this patient does not meet those criteria, right? And so the decision to then kind of take that decision about transport out of the patient's hand and go to the hospital is absolutely accurate. The next thing to talk about in this documentation is kind of management of agitation. Whenever I see an agitated patient in the ED, I'm trying to think through like what's the cause of this, right? Do I have an answer to what's the underlying cause of the agitation? So hypoxic patients, right, need oxygen. Hypoglycemic patients need glucose. This patient, her cause is probably a more complicated medical cause resulting from what looks like liver failure based on all of those exam findings, with having a distended abdomen, vomiting blood, being jaundiced. And so those patients get encephalopathic as a result of kind of toxin buildup from the liver failure. And they, there's no sort of super quick fix to that. But I do think that it's appropriate in a patient who is, really fighting you, really making it difficult, really at harm for hurting one of you or hurting themselves, to kind of pursue sedation, acknowledging that the Versed isn't fixing any of her underlying issues, right? And so it's the only kind of choice that we have. But I do think in this case that it was reasonable. Let me see. I'm just gonna see if I can invite the 74s yet. Give me a second. So again, it's when you're limited in kind of the choices of what you have, definitely think about why could this patient be altered, check off those other things when it comes to hypoxia, hypoglycemia, that sort of thing, because if you have another fix, that fix is going to be better than just throwing a sedating med at them. Once she got the Versed though, sorry, I went a little bit out of order. She got oxygen and then specifically noted that her breathing was kind of intact through the rest of the transport. So making sure that those patients who get any kind of sedating med go on capno, get oxygen if they need it, and that you're really closely monitoring their respiratory status is key. And we've kind of talked about that at other times. But the documentation of kind of like what happened, when it happened, I think was really good in this case. The one thing I would comment on here, so the patient got a 20 gauge IV in the right AC. The sort of classic teaching of known upper GI bleeds is that those patients need, quote unquote, 2 large bore IVs. So if I had a choice in this situation and the ability to do an indication, I would probably try for an 18 or a 16, just knowing that she obviously threw up blood. There's probably still some bleeding happening. We just aren't seeing it at the moment. And so one option in terms of management of this patient would be to try and go bigger in terms of not bigger in the gauge, but a lower gauge IV, i.e. a larger bore IV, so that that patient can really get resuscitated through that. I didn't see anything in the protocol about like when to get 2 points of access. And so 1 point of access in the pre-hospital setting is fine. If you're actively resuscitating and needing other medications, then that's probably when I would look. In the hospital, again, the kind of classic teaching, these patients are going to get 2 big honking IVs so that we can resuscitate through them as best as possible. And then kind of looking at her progression. So starting vitals, again, blood pressure 114/72 with a heart rate of 57. And then by the time she was like in the medic unit and almost at the hospital, blood pressure was 159/101 with a heart rate of 101. Still good respirations, good blood glucose and everything, and a stable GCS. So it's a little bit hard to know exactly sort of what was going on with this patient's physiology, right? Her blood pressure went up and her heart rate also went up. When I saw that initial bump in the heart rate, kind of my initial reaction to that is, should this patient start getting fluid resuscitated right away, right? The issue is that you guys don't have blood products, and we're fairly certain, right, that the result of this patient's, she's not even in shock necessarily, maybe she's compensated at the moment, but she's got normal blood pressure, but worsening of her heart rate. It's probably because she's losing blood, right? She's bleeding into her belly. That's what the coffee ground emesis was. And so really the answer is that we need to stop that bleeding, which has happened in the OR, or kind of replace that blood volume. And when all you have to choose from is crystalloid, then I think it makes that conversation a little bit more challenging. And so I actually dove into the protocol a little bit more. And when it comes to, when you have true suspicion that the hypovolemic shock is due to hemorrhagic shock, then really volume resuscitation is only indicated with a decline in mental status or the change in their kind of perfusion. So if this patient, just had a bump in her heart rate, it's interesting, but it actually is not necessarily an indication to start fluids. And that's in a couple of different places in the protocol. So I wanted to put it to Dr. Richards, would you want fluids to be started on a patient like this, or is the dilutional effect potentially of crystalloids, potentially risky enough that really they should wait until these kind of serious criteria are met.
Yeah, that's an interesting question. So the lowest blood pressure was the 114/72?
Yeah, that was the first blood pressure.
And
then the most notable change is like her heart rate doubled, basically.
And she is altered, which could be a sign of hypoperfusion, but she could have 100 different things causing her.
Right.
Yes.
And you get some worsening, like between these, as the vital signs are changing, there isn't an acute change in her mental status. So I think if that had been present, right, like with or without the Versed, you know, now she's really somnolent, only responsive to pain, like something has changed, then I think there would be an absolute indication and a very clear protocol to do that. Without that, you know, when I first read this again, I was like, why didn't they give fluids? But looking back at it and kind of looking at it in more detail, it actually is not necessarily indicated for this patient at this time.
I agree. I mean, honestly, I think you're probably well justified in doing either.
Yeah.
You know, the signs are certainly pointing toward GI bleeding, but it could be sepsis, it could be any number of different things. You know, I think in this situation, leaving well enough alone, what we got, I think is fine. You know, especially if it is like a little bit of like a varices, just holding on and kind of pressing her another 10 or 20 points systolic might actually put open things up. If she doesn't absolutely need it, I'm totally fine holding off. But that said, like, if you're like, you know what, like, a little bit more of a sepsis flavor to her, maybe all that fluid is going into the ascites. She looked intravascularly volume down, that's my sense. And so we, you know, trialed 300 cc's on the way. Like, I think that's pretty justifiable. But you know, in this situation where they held off, I think that's probably the right decision. Probably the reason to use itemized. So I think you're well justified.
Yeah. And I think you can make an argument for either way. The key is kind of documenting your thought process or like why you chose to do what you did. And again, generally, I think this documentation was great and gave me a good sense of what was happening to this patient or with this patient. So just want to go through kind of what we think about when we see a presentation like this. So again, the sort of summary, if I had to put this patient into like 3 symptoms, would be the coffee ground emesis, the altered mental status, and then the jaundice. And with all those things put together, I'm thinking, you know, about what is the liver doing? What is the status of the liver? In terms of general sources of upper GI bleeds, common ones are peptic ulcers. Those might be due to infection, NSAID overuse, or just in your patients that smoke. Esophagitis, which is just more kind of inflammation of the lining of the esophagus. And then esophageal varices. These are sort of the most, peptic ulcers actually can bleed really significantly and really fast. But esophageal varices are kind of like these large vessel connections that have grown or overgrown, and usually due to portal hypertension, which most commonly is due to cirrhosis, and that may be alcoholic or infectious. And then Mallory-Weiss tears, these are little kind of tears in the bottom of the esophagus that happen when someone has frequent or forceful vomiting. Again, less likely to cause large volume bleeds. And then cancer of the esophagus or the stomach lining. I mean, cancer can do whatever it wants. So if that's the cause of the bleeding, then certainly could be bad. Thinking about what portal hypertension looks like, this is a very complicated picture. It's believe it or not, the most streamlined that I could find. But if you focus on the orange boxes, kind of ignore all the blue ones, are sort of all these physiologic principles. But if you focus on the orange boxes, so basically you have scarring of the liver, the pressures within the liver build up. And so one thing that happens is that you get these collateral vessels that forms. Those are the esophageal varices. So as blood is trying to kind of like find its way through the liver and the systemic circulation to get where it needs to go, these other vessels, usually in the esophagus or this is where they cause problems, but usually in that area, get kind of dilated, get really irritated. If you look up kind of like scope pictures of these, they're these like big bulgy blue like veins. Kind of think of like the worst What do those old ladies get?
Varicose
Yeah,
veins.
and where's varicose veins? The worst varicose veins you can imagine, but like inside of your esophagus, like those like bulgy, weird shaped ones. Anyway, so that's what's going on there, and that's because the blood's trying to kind of find its way through the system. Even I don't want to be in your meeting, but I'll invite you to my meeting. Let's see. Oh. Hopefully that works. Cool. So the next thing that happens, and Dr. Richards briefly kind of touched on this, but these patients are pretty high risk for becoming septic. And oftentimes that's just simply because they have kind of this leaky gut wall and membrane that means that the normal bugs and bacteria that are in our gut kind of leak out into the system. And that can make these patients floridly septic. And then the final one over here is ascites. So this is due to kind of a whole bunch of different things going on, but around kind of like how the circulation has to compensate for the scarring and the high pressures in the liver. And so you get fluid buildup, usually in the abdomen, but it can be pleural fluid in other places. And that likely is part of the distended abdomen that this patient presented with. So again, I know it's a complicated picture, but just thinking through kind of what's the impact of cirrhosis and portal hypertension on these patients. It's multifaceted, and several different aspects of this can contribute to the patient's presentation, whether they're hemorrhaging, whether they're septic, or whether they're third spacing fluid. It could kind of all play into why these patients look and get so sick. So the follow-up for this patient, so she did have a history of alcoholic cirrhosis. On arrival, got started on a sepsis protocol, so got blood cultures, antibiotics, got an acid blocker, and started on broad spectrum antibiotics. She did have variceal bleeding. She did have ascites, and initially went to one of the step down units, but actually had worsening of her hypotension after she got admitted, so needed to go to the ICU with these kind of like her worsening circulatory status. She did go to the OR and got these varices bandaged. So there's a couple of different things that the gastroenterology doctors can do to these bleeding blood vessels. They can kind of put a little rubber band around the vessel to stop it from bleeding, kind of tourniquet it almost. They can burn them, they can clip them, lots of different ways that they can stop the bleeding. But the one main answer to ongoing bleeding is to actually go in and try and stop it. And then she got the ascites left, because she was probably the least of her concern. They felt like she had kind of this profound encephalopathy and altered mental status from a combination of different sources. So partly her liver failure, partly due to the alcohol use being the cause of all of this, and actually ended up having seizures during her hospital stay. She kind of like got progressively worse, needed to be intubated. And then eventually in a conversation with the family, they made her DNRCC. And she ended up going to hospice. I'm sorry, this got cut off. Usually does a decent job of going from computer to computer, but ended up being admitted to hospice and died kind of relatively shortly thereafter. So not a happy outcome to the case, but she was extremely sick, and I don't think that there's anything different from a pre-hospital perspective that would have kind of impacted how this was going to go. She was just super sick. Anything you want to add?
You might know this, or Lauren, how much of that like liver disease was known in advance of this admission?
It was known.
Okay, so she was kind of out of that trajectory, so
Yeah,
it wasn't like
she
denial kind
admitted-
of thing. I mean, because obviously the liver disease was advanced, but
Yeah.
I didn't get a good sense of like how much she, and maybe it was.
I think it was pretty well known from what I saw.
Yeah.
Yeah.
She had a couple previous visits, and like the family was well aware of her history too.
The only other thing that I'll kind of mention it, but I just want to make a more blunt point about it is, you bring a really nice distinction of saying that like not all hemorrhagic shock is trauma. We obviously think about hemorrhagic shock a lot in that context, and almost all the time, but like, of course, GI bleeding, you know, you can actually lose a lot of blood in retroperitoneum, like they had like a cath or something like that. either groin, maybe something going wrong, that you go out of blood here, herpes.
Or biopsy site. Oh,
Yeah,
God.
biopsy sites, even like, especially if they're on like a NOAC or something like that, and they've been like having a nosebleed all day, like you actually get a hemorrhagic shock and like that kind of stuff. So, you bring up a really good point of hemorrhagic shock, being from any number of sources, even the the outcome.
And my thoughts about her kind of mental status is probably this was acutely worsening hepatic encephalopathy.
Right,
like that seemed to be the newest thing for the family. Like they knew about the abdominal distension. Didn't seem like the jaundice was their main concern. But the like acute change in altered mental status, that's not going to be usually the kind of like alcoholic encephalopathies, like the Wernicke-Korsakoff stuff. That stuff develops over time. So certainly it contributes. But when you have an acute change like that, it is really helpful to know from your history taking, what is the newest thing, right? And it seems like this family was pretty kind of upfront that she had not acted strangely like this previously. All right. So this is the second case. So this is a dispatch for a 31-year-old female, unconscious diabetic, which already sounds nerve-wracking. On arrival, the patient is unresponsive, lying supine in bed, noted to have vomited just prior to EMS arrival. The grandmother explained that she last had contact a few hours ago. The patient is a known type 1 diabetic. The grandmother said the patient's insulin pump was acting up earlier and the patient had been trying to fix it. She was tachypnic, started heaving, and was placed in the left lateral recumbent position, and then proceeded to vomit. So hopefully it didn't get all over everyone. No blood or anything else kind of abnormal noted about the emesis, which I think is a great thing to note. And then patient remained unresponsive to verbal or pain. So yes, you can calculate a GCS, which is calculated down below. But we know that the AVPU or the ABPU scale is really a great surrogate and nice and easy to do. So this patient is fully unresponsive, right? Took a look at her insulin pump and it stated update in progress when you attempted to activate it. She was noted to be pregnant and the grandmother stated that she believed that the patient was at least 5 months pregnant. She protected her head and neck while she was moved to the Reeves, to the cot, and then to the truck. The airway was suctioned and an NPA placed to assist with the airway. Blood glucose was assessed to be 58. Vitals taken, she's noted to be hypertensive with a stat of 88% on room air. Ventilations were assisted with bag valve mask and inline capno, 15 liters per minute. Had a 12 lead that was interpreted as sinus arrhythmia. Had a 20 gauge IV in the right hand and started D10 and was transported to the Westchester ER. During transport, the patient began seizing. It lasted less than a minute. The ER was contacted again and spoke with an MD who shall not be named, and requested approval for midazolam in this pregnant diabetic seizing patient. Great summary statement. Pregnant / diabetic / seizing. I love it. Pretty much sums it up. And got approval of 5 milligrams and to administer additional doses if necessary. The patient began seizing again, and the 5 milligrams of midazolam was administered at IM in the right deltoid. During the seizing, they sort of noted that the D10 looked like it had become disconnected and the IV had been dislodged. So a good choice to use the IM route regardless. And the patient stopped seizing, mental status improved to a GCS of 14, reassessed blood glucose, and it was 132. The patient's words were slurred, but she was able to ask questions and respond to EMS. And on arrival, she was moved inside from the cot to the bed, secured, and transferred to the ER staff. So this patient's vital signs are, other than the heart rate, all abnormal, right? So she's hypertensive at 150/90. Blood pressure, pulse is 84. Respiratory rate is 22 with a stat of 88% in room air. And the blood glucose, as you guys noted, at 58 with a GCS of 5. So this patient sounds like she looked pretty awful. when you guys got there. And I think, again, thinking through, what could be happening, particularly in a pregnant patient, is helpful, but your management priorities are still going to be the same. So let's kind of pick this note apart similarly to the last one. So first thing is, the patient was placed in the left lateral recumbent position when she kind of like hinted at the fact that she was going to throw up. If you have to pick a side to turn a pregnant patient to, this is the side you want to pick to turn the patient, pregnant patient to, right? So basically you're trying to take that gravid uterus and kind of move it over to the side so that the IVC can still get good blood return to the heart. So if you're ever having to pick what direction to turn a patient into for this situation and they're pregnant, then always turning to the left is a good bet. So that was the first thing that was nicely done. Knowing kind of how pregnant the patient is important, right? So 5 months is right around viability probably, but having a sense of where you're at can be helpful. You can also kind of palpate the abdomen and see if you can palpate the uterus. Basically, if the uterus is above the belly button, then that's a good sign that they're decently far along and would probably match this patient's exam. But it's not, it's not critical to including that in this note. But it is a good, just kind of simple, quick way for you to assess like how pregnant really is this patient. And you're trying to kind of feel for the top of the fundus of the uterus. Next is the use of an MPA. So I love that this patient got an airway adjunct, right? She's vomiting, she's altered, but she's not so far out that she will tolerate an oral airway. So I think had anyone tried to put an oral airway in, it probably would not have gone well. And there would have been more vomit all over the place. But an MPA in this patient is a really, really good idea. And I think probably was helpful as they kind of continued to need to support her airway through everything that happened subsequently. And then in terms of management, again, we'll talk a little bit about kind of causes for what might be happening here, but midazolam is indicated for pregnant seizing patients the same way that it's indicated for other seizing patients. So it is still your first line go-to in terms of managing seizures, even in pregnant individuals. And again, I kind of spoke a little bit about using the IM route. And I think that was a good idea, especially as this, it became clear that there might have been a problem with the IV. But remember that the IV and IM dosing for seizures is going to be different. We know that this patient was hypoglycemic, started the treatment that was indicated, and then reassessed it. So one of the things that I've sort of come to talk about a lot more while I've been doing this year is sort of how important it is to be going back and reassessing our patients. And I think it's great that in this note was included the fact that the blood sugar was low, we acted on it, we rechecked it, it got better, but also there was a change in her mental status. Now, was that she was having sort of small seizures and it was really the Versed that helped, or was it that the sugar helped? Blood sugar of 58 wouldn't make me think that you'd be totally out with a GCS of 5. So it's probably a combination, but putting all of this in there and actually taking note of what your reassessment was is really important. More important than even writing about it is doing it, right? So anytime that you are intervening on something, go back and reassess that, right? If someone has a fractured extremity and you splint it, make sure you're going back and reassessing the pulse in that extremity. If someone has sugar issues and you've done something to fix it, either high or low, we got to go back and reassess that. Anyone who's altered, we should be reassessing their mental status frequently. So I appreciate that was kind of called out. The calls that ended up coming through to medical control were really nicely done. So kind of nice streamlined information, including the fact that you had found out that the patient was pregnant early in the call and having an idea of how far along she was, like all of that was said right up front. So I think that was really nicely done. And then the decision was made to make 2 separate calls to medical control or 2 separate calls to the hospital. The first was simply notification, right? At that point, you had an unconscious patient who was hypoglycemic. You were kind of acting on that, but she hadn't openly seized or like acted out. And so it was just notification that this is what we got. And then the second call was to medical control to actually get recommendations for the Versed dosing. And again, knowing what you're going to give, how you're going to give it, and then how you're going to reassess and kind of continue to monitor that patient's respiratory status when you're giving Versed is super important. So there's an entire protocol about pregnancy and postpartum complications, and seizure is a major complication. The challenge again with this patient is kind of what was the cause. And again, similarly to the first case, like the treatment, maybe not the overall solution, but the treatment is pretty much going to be the same, which is to do benzodiazepines. But seizures, and is it any seizure in a pregnant patient, regardless of the cause, would be eclampsia, or only if it's related to hypertension?
Certainly you presume it.
Yeah.
I mean, I guess if you have a primary seizure disorder and you have a seizure,
Yeah.
probably at some point it's going to be adjudicated with something other than eclampsia, but.
Yeah. Or if she was really hypoglycemic and that seemed to be the cause, then
yeah,
that
you're right.
would be a different reason. But eclampsia is this sort of clinical diagnosis of patients who are pregnant who have seizures, and it can happen at any time during the pregnancy. So it's nice when you have a patient who's obviously pregnant, right? But if you have to get that history, it might be a little bit harder to tell. Most are happening, if they do happen during the pregnancy, they can happen anytime. It can also happen in the postpartum period. So someone who's recently given birth can also have seizures as a result of eclampsia. And we treat it basically the same way. Key management issues are prevention of maternal hypoxia. So getting that aerion, bagging, having full flush rate oxygen like they did in this case. Treating the severe hypertension, which we'll talk about, put that on the side burner for a second and talk about it in a second. Preventing recurrent seizures with magnesium, which I don't believe you guys carry. No mag, right?
We have magnesium. We don't have enough.
We have
Yeah, a little bit. So you can start a little bit of it. And then getting them somewhere that can kind of care for both mom and baby. And getting access. And if the patient is actively seizing, then first line is the Versed, just like it is for kind of general seizure protocol. And for this patient who was hypertensive, so her blood pressure was 150/90. She's doesn't technically meet the kind of criteria down there at the bottom for initiating antihypertensive therapies, but there is this new part of the protocol that was added this year for like actual treatment of hypertension in pregnant patients, which we're not gonna do here, right, Dr. Richards? We're not gonna do oral.
We're not, at least at this point, stacking the therapy unless I've heard differently, but yeah. I'm more than happy to have a conversation. Some have adopted it, some have not. There actually is actually pretty good data and recommendations behind doing it. So we wanted to look at that, and it's an oral medication, so it wouldn't be for eclampsia. It could be more preeclampsia, but we could certainly look at because even with shorter transport times, there probably is a value.
So the oral nifedipine is what was added to the protocol in 2024. And this is basically the only place in the protocol that you find it. So again, kind of thinking through it, recognizing that we need to notice hypertension, and that there might be a reason to treat that and a good reason to kind of tell the hospital when you're going in, but not currently kind of going to be part of the practice. This obviously is not totally my wheelhouse, seizing pregnant patients or patients that I hope to never have to care for at Liberty. But again, I think in terms of the care of this patient, it was clear that the airway was a priority. It was clear that the patient was assessed and reassessed appropriately. And that kind of the two main issues that needed to be treated from the hypoglycemia and the seizure perspective were done. The timing for this, I think was only like 12 minutes or something. I have to go back into the chart. I might be getting them confused. But is there a point with this patient where you would have wanted them to pull out magnesium?
Yeah, I think if time allows, with magnesium, there's like fairly little downside until you're getting into like, 6, 7, 8 grams kind of thing. Then you start like losing some degree of like respiratory drive, or at least that's what you're supposed to like watch for you get into them. But like to give 2 grams, especially with mag, is like pretty low risk. The only thing would be is like, are you able to, with the number of hands that you have and all the rest is, I'm fairly certain that she had her seizure like during transport.
Yeah.
It would have been a nice thing to kind of round it out, but the thing that she needed was the sugar and the percent. So
yeah, especially kind of take into consideration that as she was moving around, ended up losing that 1 IV, right? Like you have a med that you can give IM that's going to be a good answer, and that is the main treatment with the midazolam. And to be able to get the magnesium in, right? There's a lot more work that needs to get done to kind of make that possible, especially once the IV goes bad. So certainly focusing on the things that you can impact. And again, going back and reassessing, especially airway and breathing after giving the Versed is super important. Any other thoughts about? I can go to the follow-up if you want.
Yeah, I think the only other thought that I had on that is, well, 2. So one is, in kind of probably TQIing myself, we probably could have done, or maybe even should have done, either 10 milligrams of IM or 5 IV, just because that's a little more consistent with like the Rampart dosing. Now it worked out for her. She ended up stopping seizing. It was fine. And she would have been more untended after that medication, but kind of the goal is to go ahead and get that seizure aborted. I think it was a really good spot, I think, to call. If it had been like a real much longer delay, just go ahead and give it. But especially with like pregnant women, like, we do want to avoid benzodiazepine. So like if like you had a 25-week-old like really anxious pregnant woman, like that's not a situation where you want to give like those benzodiazepines. So hold on in that situation. And the last thing is like probably like if you are really kind of tying up loose ends, we could have theoretically thought about like removing the insulin pump itself. Mm-hmm. Even I am like sometimes hesitant to do that, and part of the reason is like, well, if I'm given like a bunch of sugar and I have like normal sugars, I can like treat that and just give it, like maybe I'll just like defer that. So I would have done exactly that. I would have messed with the pump itself. But theoretically that could be another treatment option here, especially if we think that it's like haywire and malfunctioning and stuff. Like seems like it probably was. Like it's kind of like a ugly situation, I guess.
I think they tried to ask her like if there was any kind of intentionality to all this, and like she thought that her sugars were going too high, so maybe gave herself a bit more, and then the pump also seemed like it had malfunctioned. It seemed like in the end there wasn't like true self-harm or intent to this. Yeah. So obviously patients who want to hurt themselves, excess insulin or mess with your insulin pump is an effective way to hurt yourself for sure. So always kind of part of the question for patients who go low. So for her, in terms of her follow-up, got to the trauma bay. At that point her sugar was 41, so I'm not sure what was going on kind of with the repeat sugar that we got. It wasn't specified, and I don't think I saw it documented anywhere else, like if it was a finger stick or kind of using any part of the IV. But obviously if the IV just had dextrose-containing fluids going through it, then that could be messed up. So at that point, definitely want to do a finger stick. So when she was at Westchester, got a slug of D50, disconnected her pump, got her sugars stabilized, and ended up going downtown. They were concerned that she had aspirated with that hypoxia and kind of the whole story taken together. So got some antibiotics, but didn't seem to really need them overall, and was discharged home without any issues. So I think this definitely could have looked a lot different, right? A seizure in a pregnant patient that went unchecked or that wasn't managed quickly definitely could have been far more devastating for her. And so I think, you know, again, there's a couple of little like small details that if you have the time or the manpower that you can think about in a case like this, but generally speaking, she got the care that she needed, got where she needed to get to, and had a really good outcome. So two lives saved in that one. Questions about this case or any other comments? All right. So this is the third and final case. So this was a dispatch to Barrington for an 86-year-old female, just an unconscious person. Crew arrived on scene and found the patient sitting in her chair with the nursing staff. She appeared to be unresponsive and was breathing deeply. She did not respond to a sternal rub and her eyes were not reactive. The nursing staff stated that she was last seen normal about 20 minutes prior to EMS arrival. That she was last seen normal like 9 a.m. I think this was like around 10:30 or so. And that 20 minutes before they had gotten there is when she had gone unconscious. The patient had been drinking earlier in the day. She was loaded into the medic and was going to be transported to Westchester. And amongst all of this, the patient lost her pulse, was not breathing on the way to the medic unit. So CPR was started. Bag valve mask ventilation was done. And a minute later, the patient got ROSC and her ventilations were still being assisted with the bag. Her EKG showed sinus bradycardia at a rate of 30. So she was placed on pads and had been on pads during the cardiac arrest. At that point, the patient was paced at 70 with 75 milliamps, and with that had mechanical and electrical capture. Patient got a 20 gauge IV in the left forearm, was given a fluid bolus. At that point, she was alert and was both shaking her head yes or no to answer questions, denied being in any pain. The medic was still on site of the nursing home when the crew was handed a DNR sheet. So it seems if you're responding to a nursing home, maybe they would have that information ready for you, but clearly not. It was a valid sheet, and at the time the patient still had a pulse. So and you were able to get the patient's vitals to be stable on the pacer, and her mental status was better. So and anytime you pause the pacer, she would go back into this bradycardic rhythm. So the decision was made to transport to Westchester. She didn't need any other intervention, just continued getting paced, and then was transferred to Westchester staff. So the first vital signs that are documented on this patient are a blood pressure of 142/101, a pulse of 30, but an absent pulse. So it's a little kind of difficult to know. And then shallow irregular respirations at 10 a minute with a sat of 83% on the oxygen, an end tidal of 26, a glucose of 140, and a GCS of 3. In terms of the timeline of this, these vitals are like 4 or 5 minutes after being on scene. I think my biggest question with this case in particular is kind of what happened when, and what did the patient really look like right when you got there? So when she was sitting in the chair, what was the assessment kind of at that time? Because once the vitals are documented and kind of the narrative continues, it's a little bit difficult for me to tell when each of these different things happened. So I really would have liked to have seen vitals like right from when she was sitting there, when it seemed like she was breathing, seemed like she had a pulse, to know where she was at that point. Because had she had a pulse at a bradycardic rhythm, but had been altered, kind of sitting in that chair, then before she arrested would actually be a good time to have kind of gotten her set and pacing at that point. If she had a pulse of 30 on the monitor, or sorry, she had a rate of 30 on the monitor, but no pulse sitting in the chair, well, that patient's in PEA right off the bat and needs CPR immediately. So it's a little bit hard for me to tell with this documentation kind of exactly when things happened. And there's only two like full sets of vital signs documented for her. So it's difficult for me to know really what was happening with her heart rate and in particular her pulse kind of over the course of this. it wasn't very long that you all were with her. I think the first contact was at 10:59 and dropped off at 11:19 or something like that. So there wasn't all that much time that this took up, and obviously the patient got pulses back. But it is a little unclear, and I don't know if anyone was on this run that can speak to it, but kind of exactly what was going on in that first moment, that very first assessment. It might be engine versus medic, but I think it was just a medic unit at this run. So again, sort of the way that this is documented, it sounds like we were already moving the patient when we realized that there was a change in her clinical status. And again, knowing exactly what she looked like before starting that move is super important, because it becomes infinitely more difficult as you're moving and transporting someone to be able to kind of continue that reassessment. And so just again, speaking to kind of like how to document the play-by-play so that we know when things were happening. Great that you recognize that there was the change in pulses. Great that she got ROSC. Great that you bagged her. All that stuff had to happen. And since it was such a brief period, like I think it's unlikely that she was in cardiac arrest for a very long time. And then after getting ROSC, having that rate at a sinus brady rate of 30, again, makes me ask two questions, right? So the first is that a large proportion of your patients who you get ROSC on are going to rearrest. So my first question is this unstable bradycardia or is this PEA? And it seems like she still had a pulse during this period, so that's unstable bradycardia. And then the second is kind of what can we do to manage this? Both of the blood pressures that were obtained were normal. So from a blood pressure perspective, there wasn't an indication for push dose epi, and the arrest itself lasted so short that the patient never got epi. But epi will help with bradycardia as well. So in a situation where you're post ROSC and you have hypotension and bradycardia, often that push dose epi will be helpful for you. But I think that in this situation, with kind of the whole story taken together and what she looked like after the arrest, that pacing was the right decision. And so starting to pace her, getting the access, and doing all of that, I think was the right way to go. For bradycardia, I mean, Dr. Richards, again, we have the choice of atropine, we have the choice of push dose epi, and then pacing. For this patient, would you have tried any meds in addition to the pacing?
I mean, you could, but I really like how we just went straight to beta, especially like carry around, like about them. And you got capture after. This is the right way to approach it.
Yeah.
I mean, maybe once we'll talk more about kind of the DNR piece of it, but you know, maybe then you start thinking about atropine in the world, but where we landed and what we did, we had pads on place, we can't capture, just do that.
Yeah.
Do that.
You're already in the right place with the right tools kind of ready at your disposal, and it's clearly unstable bradycardia, right? She's not in any kind of gray zone here. She's incredibly unstable. And so definitely appropriate to pace. This next part of it, I think, brings up a lot of questions, and I imagine could have been a challenging discussion. So, you know, if you play this back 5 minutes before this and you had the DNR in hand and that patient arrested in front of you, then your hand's off, right? But the way that this played out is that you cared for her appropriately given the information that you had, and then kind of after it was said and done, but while the patient is still receiving some sort of life-sustaining treatment, you get handed a DNR. And I think that's really probably puts you guys in a really difficult situation, because a DNR is an order not to begin resuscitation. It's not an order to stop any kind of life-sustaining treatments, right? But you document every time you turn the pacer off that she brady's back down, right? So that pacer now is keeping this woman alive, basically. And yet you have this DNR paperwork. So I think absolutely that the right thing to do in this situation is to keep doing the interventions and get her to definitive care. If there were like 10 family members at the scene and it was becoming a whole deal and you needed to call medical control to get advice on that, like, then absolutely do. But I wish that the folks that were on this call hadn't been put in this situation again, because I imagine it was a combination of frustrating and disheartening and annoying and a whole lot of different things, right? This lady's at a nursing home. She should have her documentation with her. But anyway, and so all of those emotions at play, and then like, what's the right thing for the patient? But I think really 100% that the right thing to do was to continue what you now had in place, and then let them figure that out at Westchester. Any comments on that, Dr. Richards?
Yeah, I don't know. I'd be interested to hear kind of other thoughts on that.
We're not stopping resuscitation. That's the answer. If we do that, it's called murder. We're not gonna do that.
Because the patient goes right down in front of you.
Yeah.
I mean, you're not gonna like watch that happen.
I mean, you know, I've been in positions, and so the senior medics, that, you know, you have a patient code in front of you with a DNR, we're done, right?
Yeah.
We've started treatment. We're not stopping that treatment. That's a decision you all can make at the ER. We are not gonna make that decision on the street. Absolutely not. We're not gonna pause a pacer, continue with our treatment course, and if the family wants to bitch about it, let them bitch about it. They're gonna bitch about it to the staff at a nursing home, not to us.
Yeah.
We're not going to stop treatment. There's no discussion on this.
And if you had gotten this sheet 5 minutes earlier, when she was unresponsive and you kind of were on the way and she codes in the back of the ambulance.
Yeah, and she goes in the back of the ambulance. We've been in that position before.
Yeah.
It is what it is.
Yeah.
But after we've put a pacer on her and we're keeping her alive essentially, right? Because we're unstable breathing, well, we're gonna keep her alive now. There's no discussion on this.
Just
in my
stop,
opinion.
stop the monitor with pads in place and just watch.
Can't do it.
Yeah, that's.
I mean, because look at the other side, right?
I mean, I was 1,000% on board.
Yeah, we can't take her back in. We're not doing that.
Yeah.
Well, the other,
Can't change her dispo at this
but
point.
the other problem that could arise is that, let's say it was a simple fix. And we did get her back and she was fine. If we hadn't have done, if something had happened, we stopped, then the patient, then the family could be like, well, she was alive and you let her die. Or I mean, it could go many ways. I mean, whether she had a DNR or not, if they can, yeah.
And there are major talks at the state level about DNRs. I have a colleague that's on the committee for this.
Yeah.
Because it is such a gray area with EMS, and really DNRs are not designed for us. Right, like we're trying to like discern information at 2 in.the morning. Is it valid? Is it not valid? Who's it signed by? Who's the power of attorney? Like it's a friggin' mess statewide. But bottom line is, we've started treatment that's keeping her alive. That is the course we're taking.
I think that's a really reasonable way to think about it, right? It's non-initiation rather than any kind of withdrawal of care, right? So to have an order to not start resuscitating someone who collapses on the sidewalk or dies in the back of the ambulance or wherever, family member at home, like whatever it is, it's an order not to initiate that process. But once you're in it, it's a totally different ball.
In my opinion, I mean, that staff, we run this all the time in nursing homes, that staff should be held accountable. Especially if the family member is gonna be upset with us.
Yeah.
It's like, you should hold it, like, that piece of paper should be well known.
Staple it to their shirt every morning.
Wherever, yeah, right on their forehead, I don't care.
Pretty
But like, it
much.
should be known.
Yeah.
Because that's the problem we run into, especially with people in a home, like they're being taken care of by their children or whatever. What'll happen is they'll be, oh, we have a DNR. Where is it? Well, we don't have it. Well,
Well, then you
what do
don't
you
have
mean?
one.
And then, you know, it's like, to us, then you don't have one, and then they get all upset. It's like, wasn't this explained to you?
Yeah.
When the physician who signed this, did they not explain to you that this has to be present?
And this is, you know, again, there's a clear-cut answer that if we start CPR, present a DNR, cool, we're done.
Yeah.
You know, we do CPR, we get ROSC, present a DNR, we're transporting. We have the machine on her that's keeping her alive, essentially. We're not gonna turn that off.
The other piece of this too is that like, sometimes these DNRs are a bit of a blunt instrument, right? Like, I think, you have to imagine that when these things are assigned, you think about the chest compressions, the intubation, and like that kind of thing. And while it could be interpreted as written in the sheet, kind of like pacing, like, I don't think anyone thinks like when they sign these paperwork that like, hey, we could like put essentially a pacemaker on temporarily to kind of keep your heart going.
Bridge you to a real pacemaker that could keep you alive for the
Well,
next 30 years.
Yeah.
The term that's in there is the resuscitative IV. Well, what does that mean? Because if I'm treating her for sepsis
Yeah.
3 weeks prior, that's not a resuscitative IV line, that's fluid bolus and a fluid challenge, and just because she's got a DNR doesn't mean I'm not putting her on oxygen, I'm still gonna put her on monitor, we're gonna treat her for sepsis. I start pushing epi down that line, now it's resuscitative IV line because she's in VFib. Same IV.
Yeah.
But again, these documents aren't built for field providers that are doing this, but bottom line is that we can't stop treatment lines.
Yeah. And you also don't know what the conversations have been that led up to this point, right? Like, you don't know how informed the patient was, how informed the family was, how long they've had this decision or been having this discussion. So there's a lot of questions. And it's fine if everything's kind of like cut and dry and clear and there for you. But in a situation where there's uncertainty, it's unclear, the patient's status is like not just dead or very alive, like you're in this gray area. If you ever have questions or ever need backup, right? Obviously you have medical control, but again, 1000% agree and on board with everything that was done for this patient. And again, my only question is kind of like what was happening right at the start there. But at the point that they had this assessment of her arresting, getting ROSC, and then going through and making the decision to pace and everything, all of that was really nicely done, really nicely documented. So my biggest question with this case is just what happened in that first 5 minutes? What were the patient's vital signs? Because I only have 2 sets to go off of. Okay. Other questions about or comments about that case? So this is the bradycardia algorithm. We sort of went through kind of what this all looks like, but you're getting monitors on. You have meds available to you if you want, but if they're unstable or in shock, then you're moving to pacing. The other thing to think about that protocol is that for conscious patients that we're pacing in the pre-hospital setting, the main kind of go-to in terms of helping them through that is sedation rather than pain control. And so there is Versed dosing in the bradycardia protocol for sedating patients who are getting this. I have never had to pace a patient. I assume it's extremely painful. And so I don't know what kind of Dr. Richards you've had in terms of the best success in the hospital, if it's like just pain control or true sedation. But this patient ended up getting fentanyl and ketamine for the pain. She became fully oriented. And given the fact that she arrived for this patient paperwork, the physician actually had a long discussion with the daughter about kind of like how bad her presentation was, what might have been going on. Again, the discussion of like, is this now a reversible cause, which sometimes gets its its own little special box where the DNR doesn't apply anymore if we think we can fix what caused this. And ultimately they did decide to pursue permanent pacemaker implantation and made her full code for kind of this period and this event. She got a temporary pacemaker in the hospital, went to the ICU, and then was discharged with a planted pacemaker shortly thereafter. So as far as I know, still doing good.
Still kicking.
She's still drinking in the lobby of Barrington.
Still kicking.
Good for her. I'd say.
Oh, yeah. After going through this, I'd be drinking in Barrington.
Yeah. I give you all the good
Champagne.
stuff. But right,
It's called a champagne in the morning. You just call it a both. Like liquor juice in it, and all of a sudden it's acceptable.
But isn't that interesting, right? I mean, so like, if you actually like kind of parse out and find yourself in that situation, like, clearly she wanted exactly what was done for her, right?
Yeah.
By evidence of the fact that like they ended up continuing on, the external pacing as an internal pacer, and they felt really good with that. And that's why it was such a fun edge, which is why, like, yeah, had actually things gone according to plan,
Right.
we're not doing this, which is pretty wild.
And I think it's, it's that DNRs are there for people to plan for the worst, right? But there's so much reversible stuff that could happen in the interim, right? Accidents happen, illnesses happen that are unrelated to whatever your kind of progressive decline might be. And we don't always know. I mean, I have done the opposite, honestly. I have convinced a family to let me intubate a patient who was seizing because I thought in my heart of hearts that this was a different reversible problem. And it ended up in a very long, protracted, sort of difficult course for them. But you make the best decision that you can in that moment. And I love how certain you were. I don't know if in that moment, everyone has the same certainty. I think it's different. It's easier when the person's in front of you and they're like starting to wake up and you're doing something to help them. But I definitely, I have to imagine that there was some frustration and sort of like emotional response probably to the situation. I commend them for not anchoring on the fact that they were told that the patient had been drinking earlier, right? Like how many different reasons are there for a little old lady to be slumped over and altered? And that could very easily kind of slide by us if we anchor on some other unimportant part of the history, or change how we care for that patient because of some aspect of the history. So I commend the team for kind of taking everything at face value and continuing on with great care for this patient.
I mean, at the end of the day, not to belabor this, a DNR is not a do not treat, right? So, you can what if it 1,000 ways, but even if you had, let's say you had someone in a car crash, well, they got a DNR. Okay, well, they're bleeding out. We're still gonna apply tourniquets for, because the DNR does not apply to a trauma patient that of acute trauma getting smacked in an intersection. That's not a thing.
Yeah.
This is a cardiogenic shock. This is a stage 4 terminal illness thing, not an acute thing. So
not a new acute problem.
Right.
Yeah.
And I guarantee, like, I cannot imagine anyone's having conversations like thought this, that they start talking about like temporary pacing, external pacing for symptomatic bradycardia disease, that conversation. You're not having that conversation when you're filling out these forms. So I don't think folks recognize that there's a true temporizing, and like you said, what we did was consistent with her wishes.
Yeah.
Because that's what she ended up doing. It would be very interesting, like
Going to interview her.
they would kind of ask her, hey, do you realize what happened? I don't know. It's just more like, what are your thoughts on that whole component of it? And I mean, again, she's probably not going to be engaged in that conversation with us, but decision makers and all the rest, and just kind of get a thought in a general sense from that experience. I don't know. It's just interesting. It was a good case and we wanted to discuss.
Oh, do you want to speak about pain control for sedation or what your patients seem to experience?
I mean, again, interested to hear others' thoughts. My approach is to do a little bit more on the pain control side and kind of preserve mental science if I can. I feel like usually that ends up kind of doing the trick, but if you need something, you have it. I feel like 5 milligrams of ibuprofen is he'll make him pretty sleepy in those situations, especially for it could be a short limited period of time, but I don't know if anyone else has other experiences. If they need something, I like kind of pain control, at least it's for first line concern, but.
I just thought it was interesting that sedation was kind of the way that the protocol was written. I don't know if this is an area where it's worth advocating for changes to the protocol or additions to the protocol, right? Give you a choice of one or the other. I mean, obviously, you could also ask her how much pain she's in, and she says 10. There you go. There's your indication to give some fentanyl as well. It's not breaking protocol, but it was just interesting to me that that's kind of the way it went, because I've always been told, again, you guys have paced more people than I've paced, that it's just extremely, extremely painful.
Yeah. Yeah, I mean, I've never been paced myself, so, you know, I don't know what I can say for sure, but it seems like the reactions to folks is more like, maybe, yeah.
Anyone want to share their personal pacing experience?
Depends how much juice you're flowing. Yeah, what you capture at.
Yeah. That's a beautiful segue.
Begging myself down, yes, but,
Yeah.
bring me that.
We already talked about me passing out here today. We don't need more than one of us
Yeah, that's right.
taken out.
Yeah, so much.
So again, you guys this is stuff that you know, but you need both electrical and mechanical capture, right? So you're cranking up on those milliamps to get to the point where you see kind of this wide QRS with an ST segment with every single phaser spike. So here, although you get it every once in a while, this isn't adequate and needs a little bit more. But here you have kind of good electrical capture, and then you need to pair that with actually palpating a pulse. And the stuff that I read was to not do a central pulse, but actually, or at least not a carotid, because you might just be feeling kind of like the pacer moving, as it were. But you need a pulse that matches with this. So it's not just, is there a pulse, right? If their pulse is 30-40 and your pacer set to 70, then that's not yet mechanical capture. So your pulse needs to match. You need to have this QRS with an ST segment after every single pacer spike. There's a bunch of cases of SVT. I don't know, we've talked about SVT a bunch. I got bored, so I didn't present them today. And I didn't see any like major issues or holes with that. But I thought these were like, the GI bleed is interesting, physiology and pathology, and kind of thinking through like what is the source of your vital sign abnormalities, whether they're mild or major. Pregnant patients are obviously another kind of scary bucket of people, along with pediatrics. In terms of thinking through their management. And then this last case, I appreciate your guys's candid discussion is around kind of your role and how you view DNRs and everything. So that's what I got.
Thanks, Doc.
Thank you.
Thanks.
Feel the recording.
My gosh, it's kinetic.